From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Michelle O'Shaughnessy, a consultant nephrologist at the University of Galway in Galway, Ireland. Today, we will be discussing a JAMA article that she co-authored with Dr. Stoneman and Dr. Teh, titled IgA Nephropathy in Adults, a Review. This article was published online in JAMA on January 26th. Dr. O'Shaughnessy, thank you so much for joining us on this podcast.
Thank you very much for having me. It's a pleasure to speak with you today.
So to start off, can you describe the condition of IgA nephropathy?
So IgA nephropathy is an immune-mediated kidney disease. It's probably the most common of all the glomerular diseases, or the diseases that primarily affect the glomeruli or the kidney filters. And what happens is that the immune system creates these excessive amounts of an abnormal type of an IgA molecule. It's called galactose-deficient IgA1. It deposits in the glomerulus of the kidney, and it incites an inflammatory reaction, and that can lead to leakage of protein into the urine, and with time, kidney damage, and ultimately kidney failure.
And how common is IgA nephropathy in the US and worldwide?
We don't have a very good handle of the exact incidence. It's felt to probably affect close to 200,000 Americans, with an incidence of somewhere around 2 per 100,000 persons per year. But the estimates vary across different studies, even within the United States, and we don't have a national registry in the United States or in many countries worldwide. So it's probably a reasonably close estimate, but not 100% accurate. It's also probably underdiagnosed because there are a number of patients who don't come to clinical attention, either because they have very mild disease or because they don't regularly attend a primary care doctor, and potentially the disease is diagnosed too late when they already have kidney failure of uncertain origin.
And at what age do patients with IgA nephropathy typically present, and which areas of the world have the highest incidence?
Patients with IgA nephropathy typically present in their 20s and 30s, and patients living in Asian countries or patients living in the Western world but of Asian ancestry have the highest incidence.
Can you describe the pathophysiology of IgA nephropathy, and particularly the 4-hit hypothesis that was discussed in your review?
The 4-hit hypothesis in IgA nephropathy refers to 4 necessary steps that need to take place in order for IgA nephropathy to develop. So in the first step, there is an immune reaction at the level of the gut, whereby there is an abundance of production of IgA nephropathy, which then translocates into the blood and travels around the body. And the immune response to those IgA molecules, which are typically under galactosylated IgA1 molecules, is to create antibodies, IgG or IgA autoantibodies, against the galactose-deficient IgA1. And that's hit 3. And then at hit 4, these galactose-deficient IgA1 containing immune complexes are deposited in the glomerular mesangium, where they activate complement and incite inflammation, which leads to not only inflammation, but later fibrosis and permanent damage.
Can you describe some genetic and environmental risk factors for IgA nephropathy?
Despite us knowing a lot about this underlying pathophysiology or the necessary steps that need to take place, we don't know 100% all of the factors that lead to the development of this disease. There is some ancestral component, and genetic factors relating to immunity can explain up to 11% of the disease risk. But after that, there are a lot of other environmental factors, possibly relating to alterations in the microbiome, possibly relating to an excessive number of infections, particularly tonsillitis or gastrointestinal infections, that can potentially trigger or incite this immune response that can lead to the production of IgA and the deposition of that IgA in the glomerulus.
Most patients with IgA nephropathy present with some or all elements of the nephritic syndrome. Can you discuss the components of the nephritic syndrome?
The nephritic syndrome is a clinical picture that can be seen in patients with kidney disease. Some people listening in the audience might know of the nephrotic syndrome, where we have a lot of protein in the urine, edema, and a low serum albumin. In the nephritic syndrome, we do have proteinuria, but it tends not to be in the nephrotic range. So above 3.5 grams per 24 hours defines nephrotic range proteinuria. It tends to be less than that, but it's also accompanied by hematuria and oftentimes reduced kidney function and hypertension. So the clinical picture is hematuria, proteinuria, oftentimes reduced kidney function and hypertension in association with those urinary features.
And how often do patients present with episodic visible hematuria? And can you describe the phenomenon of synpharyngitic hematuria?
Up to 30% of people, and I will say again that a lot of these estimates are derived from older case series. It obviously depends on the patient population being studied and how carefully, for example, in a retrospective study, that these clinical features are picked up or reported or documented in order for them to be described. But we think that up to 30% of people will present with visible hematuria. So they see that they have red or Coca-Cola colored urine. And oftentimes that is preceded by a number of days by a sore throat. So pharyngitis or a sore throat or tonsillitis. And then within a day or two, they can get visible hematuria. And we call that phenomenon synpharyngitic hematuria. And it's quite classic for IgA nephropathy. There are few, if any, other kidney diseases that present in this way. So when we meet somebody who says they had Coca-Cola colored urine and they had a sore throat that developed a day or two prior, we have a high pre-test probability that their kidney biopsy is going to show IgA nephropathy.
So that leads to my next question, which is, what is the initial differential diagnosis for IgA nephropathy?
So when a patient is detected to have hematuria and proteinuria, oftentimes this would be picked up at a routine medical visit. They may be coming for a medical visit with an insurance company. They may be coming for some other reason. They have hypertension and someone thinks to check their urine. And you discover hematuria and proteinuria. The differential for that starts out quite broad. So first of all, you have to think, are these true, and unrelated? For example, the patient is an older person with diabetes who's a smoker. The differential diagnosis could be as broad as they have background diabetic nephropathy, they've had proteinuria for a number of years, and now they've developed a bladder cancer or a urinary tract infection, and the bleeding is coming from the bladder and the protein is coming from the glomerulus. But in a patient who otherwise, has no other explanation, they don't have bladder cancer, they don't have diabetes, and they're coming de novo with newly detected hematuria and proteinuria, particularly if they're in their 20s or 30s and not multimorbid, we're really thinking that this is a primary glomerular problem. So it's a kidney disease that's intrinsic to the kidney. And that can be either from a disease like IgA nephropathy or other diseases that can cause the nephritic syndrome. Depending on the patient's clinical characteristics, a few that would potentially mimic IgA nephropathy. So the ones that I would think of in a young man or a young woman would be IgA nephropathy, lupus nephritis, particularly if it's a woman, post-infectious glomerulonephritis, potentially Alport syndrome, which is a genetic glomerular disease, or these rarer diseases like membranoproliferative glomerulonephritis or C3 glomerulopathy. So these are, at this point, really, if you see proteinuria, hematuria, in a younger adult in particular, you're really thinking of referring this patient to see a kidney specialist because these are quite specialized diseases. But of course, you should be coming up with a differential. You should be excluding potentially confounders of this clinical picture of nephritic syndrome. And you can start to think about some diagnostic testing that you could even do in primary care or in general medicine before you refer the patient or as you're referring that patient on to see a nephrologist.
And can you discuss which laboratory tests and imaging studies should be performed when you have the patient you suspect could have IgA nephropathy?
Yeah. So I will see in clinical practice that there are some physicians out there who do a whole load of testing that is completely appropriate in these patients, and I would commend them. And there's no harm to start thinking about the tests or the differential diagnosis for this clinical picture. So there's a battery of tests. It's often serologic testing that's done in glomerular diseases. Obviously, you have to think about the cost of these testing and how likely it is that the patient has one of these diagnoses. And I wouldn't order all these tests on every patient who you meet who has hematuria and proteinuria. But if you have a high suspicion for these underlying diseases and there's no clear explanation for the patient's hematuria and proteinuria, it would be reasonable to order the following. So we test for a number of viruses. And this is for two reasons. We test for these viruses because they are associated with glomerular diseases. But secondly, we test for them because we might be considering immunosuppression or modulatory therapies for this patient down the line, and we want to exclude underlying latent diseases. But HIV, hepatitis B, and hepatitis C are associated with glomerular diseases, not necessarily IgA nephropathy, although there are some associations there. And then we would test for a screen for lupus, so an ANA plus or minus double-stranded DNA, and complement C3 and C4, which can be low in lupus nephritis, or an anti-immune complex kidney disease. Particularly if the patient has kidney impairment, we can check an ANCA, which is an anti-neutrophil cytoplasmic antibody, or an anti-GBM antibody, which is an anti-glomerular basement membrane antibody. They typically present with what we call rapidly progressive glomerulonephritis. So if the patient has completely normal kidney function, then potentially you don't need to test those at that stage, and it may be a waste of resources. And then there are some additional testing we would think about in older patients looking for an underlying paraprotein. And then there are some other tests that we would do and specific indications that probably the general physician or even the general nephrologist wouldn't necessarily think to do, but looking for conditions like thrombotic microangiopathy and other more rare causes of a nephritic syndrome presentation.
And your article discusses that adults with suspected IgA nephropathy who have proteinuria of 0.5 grams per day or more should undergo a kidney biopsy. What are the diagnostic findings on kidney biopsy?
This threshold for performing a kidney biopsy of 0.5 grams or more has actually lowered in our most recent international best practice guidelines. And that's really because we know that patients who have above 0.5 grams per day of proteinuria are at higher risk for kidney failure in the future. So we want to diagnose this condition early, and the only way to diagnose IgA nephropathy is by kidney biopsy. So the features of IgA nephropathy on kidney biopsy will show an IgA-dominant glomerulonephritis. So you will see an inflammatory lesion in the glomeruli. There is mesangial proliferation or mesangial hypercellularity, so too many cells in the mesangial area. There is endocapillary proliferations in some cases, which is an excess of cells kind of stretching out to the capillary walls. And then you will see by what's called immunofluorescence microscopy, you can see what types of protein are stuck in the kidney and potentially inciting that inflammation. And you will see a predominance of IgA. Now, as we spoke earlier about the differential diagnosis for nephritic syndrome, once you've done the biopsy and you discover what is a histologic picture of IgA-dominant glomerulonephritis, then you have to think a little bit more about, is this definitely IgA nephropathy, or could it be one of a handful of conditions that can cause IgA-dominant glomerulonephritis but aren't what we call idiopathic or primary IgA nephropathy?
Your article also discusses secondary IgA nephropathy, and I was hoping you could mention some of the most common causes.
Secondary IgA nephropathy, this is a tricky thing to explain, and in preparing this review, it's very, very hard always to know if this is primary IgA nephropathy. And what we mean by that is IgA nephropathy that follows that 4-hit hypothesis. It's sort of an autoimmune or immune-mediated condition that is due to an underlying abnormality in the way these patients produce IgA molecules and in the way their body responds and creates immune complexes to these IgA molecules and the way they deposit in the kidney. But when we talk about secondary forms of IgA nephropathy, that's where we believe that there is another underlying disease process that is primarily driving this IgA-dominant glomerulonephritis. And there are a number of diseases that have been well described to increase the risk for IgA nephropathy. And in some of these diseases, the mechanisms are explained. So for example, in inflammatory bowel disease, you can imagine this is a disease of the bowel. There's increased production of IgA at the mucosal level. We're not sure actually whether or not it's galactose deficient IgA1 or not, but certainly there's increased stimulation to the production of IgA. And we feel in those settings that potentially it's this GI disease, this primary inflammatory bowel disease, that leads to an excessive production of IgA, and some of that IgA gets stuck in the kidney and causes inflammation. But we feel that if this inflammatory bowel disease was treated, then potentially the IgA nephropathy will go into remission, and that this is a IgA-dominant glomerulonephritis or a form of IgA nephropathy that's being caused by the inflammatory bowel disease as opposed to a second kind of disease that's unrelated to the inflammatory bowel disease. And there are a number of conditions. Some of them are GI or gastrointestinal conditions. So the classic ones are inflammatory bowel disease, celiac disease, and liver disease, particularly cirrhosis and alcoholic cirrhosis. And then there are a whole other battery of things. And to be honest, in glomerular disease, anything can cause a glomerular disease. So certain viruses, we mentioned HIV, not necessarily hepatitis B and hepatitis C, in fact, but they can cause a form of immune complex kidney disease as a phenomenon called HIVIC or HIV-associated immune complex kidney disease. And that can look a little bit like lupus, or it can look a little bit like IgA nephropathy on kidney biopsy. There are other rheumatologic or autoimmune diseases, things like ankylosing spondylitis or rheumatoid arthritis. Again, we feel that it's the other disease that's stimulating the immune system, inducing the production of IgA, which is then getting stuck in the kidney. But if you eliminated the other disease, the IgA nephropathy would go away. So these are these secondary forms of IgA nephropathy. But like a lot of things, we don't know, whether the two, or they just happen to have two immune-mediated kidney disease that occur contemporaneously or sequentially, or whether one is truly causing the other. But we tend to treat the underlying disease and hope that that will also treat the IgA nephropathy.
And your article mentions modifiable and non-modifiable demographic, clinical, and histologic factors that are associated with the increased risk of kidney failure in these patients. Can you discuss these, and what is the strongest predictor of adverse outcomes?
We already mentioned in the context of when to perform a kidney biopsy, but study after study has shown that the amount of protein in the urine is the strongest predictor of kidney failure in the future. It's tricky because the proteinuria itself is a marker of how inflamed, for example, the biopsy is. So of course, if you have worse IgA nephropathy, it'll manifest as worse proteinuria. So is it truly causing the decline in kidney function, or is it just a marker of the glomerular inflammation? Is it a mediator? Is it a confounder? How exactly is the proteinuria causing the kidney failure? But we do know from other kidney diseases that even if we can reduce proteinuria by non-immune mediated mechanisms, we think and we believe from other diseases that the protein, as it travels through the tubules, incites inflammation and fibrosis. So even if we don't switch off the disease process, so even if the inflammation in the kidney goes unchecked, if we can reduce proteinuria by reducing glomerular hypofiltration, by reducing blood pressure, by reducing BMI, by reducing other factors, then we potentially can improve kidney outcomes and reduce the risk for decline in kidney function and kidney failure. So that is the strongest. The other modifiable factor is hypertension, and that's probably the second most important modifiable risk factor. So we try to reduce proteinuria as a treatment target, and we try to control blood pressure as a treatment target. After that, there's a mix of modifiable and non-modifiable, and I can refer you to the long table. There's some things like histology that we can potentially modify, things like inflammation in the kidney. And there's a thing that we use called the MEST score, which stands for mesangial hypercellularity, endocapillary hypercellularity, the amount of glomerular sclerosis, the amount of tubular interstitial fibrosis. There's an argument some of that is non-modifiable, it's part of the disease. And then there are other factors then like smoking, obesity, that are shown in epidemiologic studies to be associated with an increased risk for kidney failure. But we don't know, for example, if you drop your BMI by 5 kilograms per meter squared, whether you'll definitely have an improved outcome. We're extrapolating from other CKD studies, but it hasn't been proven as such in IgA nephropathy.
For patients diagnosed with IgA nephropathy, which behavioral modifications are recommended?
In the patients that I see in my practice, the main things I will recommend is to do all the healthy things that you would do for somebody who has cardiovascular disease or diabetes. There is very little specific to IgA nephropathy in terms of behavioral things. So there's a lot out there on the internet about what to do with diet and IgA nephropathy, and there are a lot of theories which may have some merit, like reducing antigenic stimulus, like following a very low protein diet or a vegan diet or avoiding gluten. They all theoretically potentially could work, but none of them are proven interventions. So the only dietary intervention that I recommend to my patients is to reduce sodium intake. Again, I'm mostly extrapolating from CKD literature, but we do know that increased sodium in the diet or increased salt in the diet leads to glomerular hyperfiltration, can increase proteinuria, can increase blood pressure. So we try to reduce sodium in the diet, try to achieve a healthy BMI, again, extrapolating from CKD literature, stop smoking and control lipids. But these are all behavioral modifications that we would recommend for anybody with chronic kidney disease or anybody with cardiovascular disease. And if anybody tells you that people with IgA nephropathy should follow a particular type of a diet or take particular type of supplements or take probiotics, some of these things make sense, and I'd love if a probiotic or if a change in some antigenic stimulus or if avoiding gluten could switch off IgA nephropathy. But thus far, we just don't have that evidence base to recommend anything above and beyond what we would recommend for patients with any form of chronic kidney disease.
And your article mentions the KDIGO, Kidney Disease Improving Global Outcomes 2025 Clinical Practice Guidelines for the Management of IgA and therapies that are recommended to reduce the formation of IgA-containing immune complexes that will decrease glomerular injury and manage the nephron loss. Can you discuss these medications and which patients should receive them?
Yeah, so primary IgA nephropathy has seen an explosion of research in the last 5 years. And this was largely motivated by a decision. There's a group of people involved in the Kidney Health Initiative, including the American Society of Nephrology and the NIH, and they proposed to the FDA that proteinuria is what is called a reasonably likely surrogate outcome for IgA nephropathy, based on their assessment of prior clinical trials and observational studies, that if you can show you reduce proteinuria, then this will translate to slowing kidney function decline. So on the basis of the FDA accepting proteinuria as a reasonably likely surrogate outcome, there was a huge interest from pharmaceutical companies then in studying IgA nephropathy, which was amazing for patients living with IgA nephropathy. So there were no evidence-based licensed therapies for IgA nephropathy 5 years ago. And now there are 5 in the United States, in fact. So what these trials tend to do is they will study a drug, show that it improves proteinuria at 9 months, and that enables the FDA to grant accelerated approval. And then if they show that that translates to a lesser decline in eGFR at 2 years, the FDA will grant full approval and the drug will be fully licensed and available in the United States and in other countries. So there has been a flurry of activity in IgA nephropathy such that the guidelines were updated in 2021, showing really none of these new therapies. And then again, just published in October of 2025, we have the updated guidelines, which again are almost going out of date. But in those guidelines, we have a new approach to IgA nephropathy. So previously we would say, do all the lifestyle factors, do the general CKD therapies, and then consider systemic corticosteroids, which have their risks, as anybody who prescribes corticosteroids would know. But now we're taking a new approach to IgA nephropathy that really speaks to the 4-hit hypothesis and the pathogenesis of IgA nephropathy and how different therapies have been developed to manipulate or to target these different steps in the pathogenesis. So in terms of the treatments that are now available to us, we could have a therapy that will stop the synthesis of pathogenic forms of IgA and these IgA-containing immune complexes. So that's steps 1 through 3. And then at step 4, where we have this inflammation in the kidney after the immune complexes are deposited, we can think about therapeutics that would dampen down that inflammation. At the same time, we have the backbone of therapy, which is controlling blood pressure, the cardiovascular risk factor management, and all the therapies that will reduce glomerular hyperfiltration, which potentially could be used as lifelong background therapies. But now we're thinking more that this is an immune-mediated kidney disease, and we need to think about switching off or reducing the production of the pathogenic antibodies, as well as the inflammatory response in the kidney to these antibodies. And this has been a real transformation in how we manage IgA nephropathy in the last 3 or 4 years.
And what is the prognosis of patients who are diagnosed with IgA nephropathy?
There used to be a feeling in clinical practice in nephrology up until about 5-10 years ago that IgA nephropathy was a fairly benign kidney disease. As you watch these patients from one clinic visit to the next, their GFR may not decline much. They might sit there with a urine protein of 1 gram, and you might watch this patient and their GFR might go from 65 to 63 to 59, but they're not rapidly on a pathway to dialysis. But now we know from larger epidemiologic studies that follow patients over a time course of decades, as opposed to over a time course of months or years, that the vast majority of patients with IgA nephropathy will go on to develop kidney failure within 10 or 20 years. And this has now transformed our thinking in IgA nephropathy. There was one larger study, a national study registry based in the United Kingdom that's highly cited at every talk I go to on IgA nephropathy now, where patients, if they live to their life expectancy, are almost guaranteed to develop kidney failure unless their eGFR decline can be reduced to normal physiologic decline, which is about a decline of 1 ml per minute per 1.73 meters squared per year, and their urine protein can be maintained at less than 0.5 grams per day. So they're called RaDaR, based on the Rare Kidney Disease Registry in the UK. These RaDaR data are highly cited and have really, alongside all the new clinical trials, have really transformed the way we think about IgA nephropathy as a disease that needs treatment and needs treatment now, as opposed to a disease that we just observe and we watch these patients slowly but surely go on to need dialysis or a kidney transplant.
So that's very interesting. With the advent of these new medications, do you expect that the rate of decline in kidney function and also the incidence of kidney failure may decrease?
I mean, that is really the hope, and that's what the studies are showing. I don't want to favor one therapeutic over another. And for this audience, we need to have obviously comparative studies before we can say that one treatment is better than the other. But some of these new therapies are shown to completely flatten the decline in eGFR. So usually in a clinical trial, we might see over the space of 12 months a decline of maybe 3 mils per minute per 1.73 meters squared in the intervention arm, and 6 mils per minute per 1.73 meters squared. Or I say to my patients, 3% decline in kidney function versus 6% decline in kidney function with the active versus placebo arm. With some of these new therapeutics, we're seeing zero decline, maybe 0.6% decline in the active arm versus 6% decline in the placebo arm. So they seem to potentially, we need some biopsy studies to prove this, but they seem to potentially switch off the disease process and restore the kidney to normal physiologic aging, or that very slight decline that we see in patients with normal aging. So there is this potential that IgA nephropathy is a treatable disease, that we could truly get patients into remission and we could completely eliminate. Now that's obviously very very aspirational of me. Like there's probably no disease where we can eliminate bad outcomes, but certainly where we can, for a majority of patients, restore their kidney function decline to normal aging and prevent them from ever needing dialysis or a kidney transplantation, which are obviously the outcomes that matter a lot to patients. They don't really mind if they have urine protein or if they have a slightly reduced GFR, but they mind if they die prematurely or if they end up on dialysis or if they end up needing a kidney transplant.
Thank you so much for sharing your thoughts with us about this interesting topic. I'm Dr. Kristin Walter, and I've been speaking with Dr. Michelle O'Shaughnessy about IgA nephropathy. You can find a link to the JAMA Review article we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.